Good morning, everyone. Welcome to New York to the Mount Sinai Live Endovascular Live Case webcast, like we do every month. I am Karthik Guja, and I have with me Sadar Farhan.
Hello.
So we are here to welcome you for the. Because I think just before going, PK, if I'm not wrong, this is we have crossed 100 cases.
Yeah, we're well over now, 103, I believe.
Yes.
Yep.
So we have successfully completed about 100 cases now. So, with all your support and everything, we've been doing continuously with complicated cases. PK again and Dr. Krishnan and Dr. Kapoor again have a very interesting case for us today. Before going live to the cath lab, I just want to remind you that the next live case webcast is on September 23rd. And the previous live cases have been archived into ccclivecases.com. So if you have any questions, we would love to hear them from you, and they will be promptly answered by Sardar Farhan here. So the questions can directly be diverted to him. I'm just kidding, just all of this. So,
Of course.
let's, without any delay, let's go to the cath lab here. Dr. Krishnan and Dr. Kapoor are waiting for us. Good morning, guys.
Well, thanks so much, Karthik, and that's a very nice introduction, and it really is a testament to our team and our fellows and the really the entire hard work that everybody's done that we've been able to get over 100 cases. As you know, Dr. Sharma started this before us and has reached, I think, well over 130 or 50 cases. I don't even want to misquote because he'll ask me why I misquoted. But it's a testament to online education. It's a testament to hard work and dedication towards education. So the other thing is, I also want to thank all of you who've been sending questions. The questions have really gone up quite a bit in the last, I would say, month and a half from all over the world. There was one I shared with our current fellows as well as Dr. Sardar from India on a CLI case. Part of what we do here is to try to, collaborate in a global manner to be able to try and help. It's not that we have all the answers. We know there are a lot of great people doing a lot of great work out there, and I think the collaboration is the main reason we do this, and to try to come up with some sort of consensus in this confusing vascular world without a lot of data that's really concrete. So, with that introduction, I want to introduce our team. To my right is Dr. Kapoor. All of you know him very well. He's the director of endovascular interventions at Mount Sinai West, or Mount Sinai St. Luke's, excuse me. And right next to him is Raman Sharma. You met him in July. We're missing Sri Avadani. She's on vacation, but these are our two endovascular fellows this year who've been doing an incredible job. Next to Raman is Michael Cryer. He's our interventional fellow who's been very, very interested in endo and has been doing a great job. Behind him is Elizabeth Holton, and then Damien are here to support the case. So we have a really interesting case that Vishal, I, and Raman picked out, and Sardar. This is a nice case because I think it brings up a lot of discussion points, and I think the point of today will be an algorithmic approach to a lesion that I think is very common in our practice. However, I think to come up with an algorithmic approach is going to be very, very difficult because we all have different ways of skinning the cat. So without further ado, I'm going to have Raman present the case, or Dr. Sharma present the case, and we'll go forward.
All right. So again, welcome to today's live case. And today, a very common case that we will see ourselves intervening upon is an SFA CTO. Next slide, please. So our patient today is a 55-year-old male. He was referred to Mount Sinai for ongoing bilateral lifestyle-limiting lower extremity claudication that was in the calves and feet that progressed to rest pain over the past 1 to 2 months. That was Rutherford class 4. And he reports bilateral symptoms. He has a pertinent medical history of diabetes. He's obese with hypertension, hyperlipidemia, current smoker, and depression, as well as some prior heroin use. And he's on a slew of medications, including metformin, some antipsychotics, and some Crestor, as well as methadone for his prior heroin use. Next slide. Before now, this is a two-part case because the first part has already happened, and he had an ABI that was performed at an outside hospital that showed both abnormal ABIs on the right and left, and a duplex was suggested of a bilateral SFA disease. showing both monophasic waveforms in the SFA and ATA levels on the right, and a significant velocity drop in the proximal SFA. Next slide. He was here previously, just about a week or two ago, and at that time he was complaining of right greater than left symptoms, and he underwent right SFA CTO intervention using our pretty standard techniques. The lesion was intervened with a stiff glide wire with a navicross, and later with a distal filter placement, followed by atherectomy, DCB, and supera stent placement. There was some distal thrombus burden on the filter, which is then addressed with penumbra mechanical thrombectomy, and some distal embolization to the ATA, which was addressed with PTA as well as some atherotomy. Next slide. And these are the final pictures from the previous angiogram, showing the SFA CTO lesion that was treated both with the directional atherectomy, DCB, and the final supera stent placement. Next slide. And at the time when we did our initial runoff on the left side, we saw this long segment SFA lesion of the mid, roughly 15 or so centimeters, with diffusely collateralized vasculature in the SFA portion. Next slide. So, as we were saying, there's a lot of different teachings that we can speak about for SFA revascularization, and one of the first, we're going to do a lot more talking during the case as well, as far as Dr. Krishnan had mentioned about an algorithmic approach. But a few basics we're going to be going over right now will be access methods for lesion crossing, and then also just some basic information regarding the current therapies that are available. So as far as access, the considerations that have to be made are whether contralateral versus antegrade access would be appropriate or required, or would a retrograde reentry technique also be needed. And we'll talk more about that momentarily. As far as lesional crossing, there's you have true luminal crossing, you have subintimal crossing with reentry, our typical STAR method. And then we also have our re-entry devices, the Pioneer and Outback, as well as some crossing catheters for the true lumen that are also available. And finally, our DCBs and DES, BMS, self-expanding stents, and all the roles for atherectomy and filters we'll be getting into today. Next slide.
So let's stop here. That's a great introduction, Larman. That was a fantastic presentation of the initial stuff. Before we get to your lecture, I want to have Vishal go over the angiogram and then talk a little bit about what he sees, and then we can get to the questions to everybody.
Right. So as Raman talked about, they fixed the right side last time, and now we are aiming for the left SFA. So usually our approach, with PK will talk about as well, is to go on the contralateral side and go up and over. So we took the right common femoral axis. It was very favorable common femoral, not much degree of calcification, so that wasn't a limiting factor. This is an iliac shot again, not that bad. The tortuosity is not significant, neither is the calcification. So it's a very favorable arch for approaching in the up and over fashion technique. And this is our initial runoff, which we usually do. And here you'll see the degree, the extent, and the length of CTO and a distal runoff. I'm going to show you some DSA shots just to quantify the whole stuff. But before we do that, you can actually see there is good distal runoff with at least 2, maybe 2.5 vessel runoff with some diffuse PT disease. But essentially, the AT and peroneal and distal popliteal looks great. Going back proximally, we take pictures to define.
The foot first?
Yep, sorry. Yeah, that's the foot. I apologize. Yeah.
So it's important, again, to see the foot, because if you do embolize, at least you know that the posterior tibial was occluded when you started.
Right. And also, if worst case scenario, you have to come retrograde, you actually have to know where to stick and how your vessel, if it's healthy at the foot region, the dorsalis pedis, and the distal AT region. And then we take our proximal DSA shots to define the anatomy. And here you can see proximally it looks okay. It's mainly the main the mid SFA segment, which has distal reconstitution via collaterals. You can see a big collateral coming laterally at the proximal segment, but this is a magged up shot, and this is one of the views.
So I think it's a good place to stop. Karthik, Sardar, Vishal, Raman. What do you guys think in terms of access points? How do you, let's go algorithmically the way Raman presented in his initial presentation. When do you decide retrograde up and over, antegrade, and pedal? Because as we all know, there's a big pedal, push to do pedal access for these kind of cases. So I'm just curious, Vishal. Why don't we start with you, Vishal?
So for me, if it's a standardized case and we already know the anatomy from previous angiogram, and up and over here should be feasible, doable, and that's my personal to-go strategy as the first step. Of course, defining the anatomy. If it's a ostial flush lesion, then there might be an approach of up and over versus retrograde. But if it's a mid SFA CTO, then up and over is and the anatomy and the iliac arch is favorable. I usually go contralateral access with up and over. My pedal primary first in this case is very limited and very restricted because I try to, for delivery of my devices, re-entry devices, if need be, it gives me more flexibility if I have a bigger lumen catheter, which I get access from the CFA. So for me, that's my to-go strategy. Here, if somebody wants to do an antegrade, you're not wrong because you have the anatomy defined, so you could do an antegrade access. But because it's mid SFA, I don't think there's a big difference between up and over versus antegrade, especially when you have to do pushability and your for delivery of devices. So for me, this should be just up and over.
Sardar, what about radial? I forgot to mention radial.
Radial is also now a big option, and many people are talking about it to reduce the risk of bleeding and hospital stay, and thereby also hospital costs. But the issue here is you need devices where you are able to push and have enough support. The question is, if you start with radial, you will have less number of devices which you can utilize for crossing this lesion. You are limited to some catheters, like the Navicross, for example. You have to use essentially the Terumo platform of devices are suitable for radial to peripheral, but it's for this case, I think, not the best approach to start with.
So, Karthik, one more question that's often been asked is what are some of the angiographic factors that you look at when you look at a CTO in order to make a decision on pedal access versus no pedal access?
PK, if you look at this angiogram, particularly per se, right? We always talk about CTOs, like, you can cross this CTO, not cross this CTO, but I think there is a pretty good algorithm in the coronary side. I think even on the peripheral side, there is an algorithm where you can look at the caps of the proximal cap and the distal cap and decide which option is probably the best option to choose. Like there are 4 kind of CTO caps. The first CTO cap we normally talk about is a concave cap on the top and a flat cap on the bottom, which is most favorable one, where you can just access it from above and cross it nicely cross from below. That tells you that the fibrous nature of the proximal cap is not bad, and the distal reconstitution is just a subtotal CTO. The second one is you have concavity on the top, concavity on the bottom. It's like an X-shaped lesion, which is also very favorable, but there is fibrous cap on the top and on the bottom. So once you cross the proximal cap, crossing the bottom cap will become difficult, but much more favorable to do it from antegrade approach. Now, there is the third cap, which is a kind of a complex cap, which you have a convexity on the top.
Do you have this Raman in your lecture? You know what? Raman has got this.
Okay, so it's
you're right.
So
basically going, yeah. Okay, so I think
caps. So hold on a second. So you're going to look at the caps and you're going to decide. But I think my question more is, see, all that stuff really hasn't been validated. And
Yes.
we talked about it just a little while
Yes.
ago offline. I think that this personal experience, and I think it adds a lot to our approach to these cases. But without validation, it's very hard to take that as dogma. And I think the coronary stuff has been validated very much over and over again. And I think that's important to tell the audience. But I think here, what I was really looking for is really trying to understand, because there's this push towards getting pedal access to try to cross these lesions. And what I want to really stress to everybody is that You can follow the CTOP classification. You can do whatever you want. But I think what's important to remember is really look at some of the predictors of failure, which have been consensusly agreed upon in numerous conferences, but really have not been validated. So a couple of things you can really agree is severe calcification or flush occlusion. I think most of the people who do a lot of these would agree that if you have a severely calcified cap or a flush occluded cap, you'll definitely have difficulty crossing, in any direction. Second would be if you have a cap with a flush occlusion with multiple side branches like you have here. So here you have a cap that's flush occluded with multiple side branches. Other than that, honestly, I think that the reason to come distal antegrade, retrograde access through the pedal is really zero in our practice. But I still think you should have an opportunity to try the regular antegrade approach prior to going distal. But we have a lower threshold of getting pedal access just to cross in these lesions, not to treat. So Raman will go over the CTOP classification in a second. So now that we talked about access and approach and some predictors in our experience of not succeeding, tell me what wire will you choose? This is another controversy. Do you go with an 018 system? Do you go with an 014 system? Do you go with an 035 system? And I think if you talk to different people who are very experienced, they believe in one system. So I'm curious on our approach and how would you guys make that decision? Again, we'll start with Vishal.
So, I mean, it all depends like the anatomy of the proximal cap. So if you have a favorable cap and an entry point into the CTO, then I would probably just be aggressive enough and go with an 035 stiff glide wire, whether angle or straight, depending if you have an angle catheter, you could use a straight stiff, or even you can use an angle glide wire. If it's a flush occlusion and you really don't know where the ostium is, I'm not that aggressive enough. So I try to wire with a 014 stiffer coronary wires, like the CTO wires, try to get some traction. But remember, whenever you try to pass a stiff catheter over an 035, the 035 wire will keep popping into your collateral, So just trying to find that hinge or trying to find the wire to latch onto the CTO. I'll use my 014 or 018 stiffer wire to gain some entry or pretty much drill into the CTO and then exchange for an 035 wire and then advance to it. So usually an 035 with a favorable beak, otherwise start on a lower caliber and then go up as required.
Karthik and Sardar?
I mean, Vishal mentioned a very important point. I mean, here you have the collateral, a very strong collateral, essentially supplying a lot of the distal part of the thigh. So you don't want to destroy this collateral by dissecting with a 035 wire directly there. If you identify a cap, which I believe there is, there might be this one exactly, might be the cap of the CTO. From here, you can actually go with a 035 wire, glide wire, or actually try the approach of Vishal with a 014 wire. Both approaches are feasible actually and doable.
Karthik?
I always start with 014 wire. So no matter what the cap is or everything, I just if I know that it's a long segment lesion, then I know I have to be aggressive enough with an 035 wire. I think for me, more than I think cap matters. Definitely a collateral like this matters, but I think calcification definitely matters a lot. The length of the lesion matters a lot. But I think here I would definitely go with, I always start a cap with 014 wire and then decide if I have to escalate. I always escalate the wires, 014 to 018 to 035. But here I would definitely start with 014 wire. I think
and the reason being?
The reason being, again, it's my technique to always start with the 014 wire, but definitely here, because I don't want to dissect the collateral, especially that collateral. And even if you're in that cap, I would not still use an 035 wire because that might be a cap, but if the 035 wire, there's a high chance of perforation of that small branch if you use an 035 wire directly there. I think 014 wire gives you a chance, even if you perf, I think 014 wire gives you a chance to recuperate and make sure that you can contain the perf. This is a mid-type perf, so if you can, I mean, I'm sure we can cross the CTO, but antegrade or retrograde, but I would definitely try to avoid the pain for the patient if it's possible.
So
but the risk of perf is high.
Okay, but I hate to be a naysayer here, but honestly, like, why do you give a poop about that collateral?
The other collateral is more significant.
I mean that collateral doesn't supply anything. So collaterals become important when what supplies the lower limb, right? So when this is why the initial angiogram is very important, as you all know. So you see the initial angiogram, so you're looking at the occlusion, you're looking at the profunda, and you're looking at how the distal SFA fills. If you have an SFA to SFA collateral and that comes off at the level of your occlusion, then that collateral is significant. If you don't have an SFA to SFA collateral, and in this case, in the runoff, that's why it's very important to perform good runoff the way Raman did here, or Sardar did here. You can see here that you have a beautiful collateral via the geniculate to the distal SFA. And I am on a hypermag view here. I'm on a hypermag view here showing you the cap. So you already know that this collateral is insignificant. So yes, you can perf it by getting into it. I agree with that. But I don't think this collateral has any value in terms of any sort of significant blood supply that's going to cause any pain to this patient. As you know, we often close collaterals in the SFA when we do it. And we always are careful about the distal genicular collateral, which causes if the stent goes down, is going to go ahead and keep the leg open. But this collateral is not doing anything. So to me, yes, it might be supplying some muscle fibers, but I'm not concerned at all in this collateral. I do agree with your other point that the 014 wire gives you the ability to torque properly, gives you the ability to be,
contained.
Or just, I don't think you're going to
More
perf.
control.
I just think refined in your approach, because with an 035, you're going to be a big bully. So, I think that the other technique that Raman recorded here also shows that what Vishal and I did, we were able to track the catheter. We were able to find the little collateral. You can see there's a little branch that comes off. There's a little stump, and then there's a little segment, I don't know how you can see it, that comes off. And that segment is likely what's going to be it. So I agree to get into that. You probably need an 014 wire, but you can probably do an 035 as well. So, I mean, I think these were great points, and I think it's important for the audience to see. So again, I guess to summarize, as far as access is concerned, everybody in our group, which is a very busy group, feels that antegrade is probably the best access here. Some consideration to pedal access as a mode of crossing if we have any difficulty. Really no consideration to radial because of lack of length of modern devices, I would say, other than just available bare metal stents that may reach this. And also, and antegrade access is reasonable, but although we feel it's probably not necessary in this case, like Vishal said. To summarize in terms of our wires, I think it's you heard the discussion. Anywhere from 035 to 014 to 018 is acceptable, but here I think, like Karthik said it best, it depends on the cap, and Vishal said it as well, how you want to penetrate the cap. So what wire should I choose, guys? I'm going to let you guys help me do this case. What are we going to choose?
It's a dealer's choice.
I would start with a command wire if you're choosing an 014.
All right, let's go with the command wire.
I think
for first time, Sardar agrees with us.
Command wire it is.
No, it was PK. So PK gets an 035 straight up down.
In my hands, this will be an 035.
See, I'm telling you. Me and Karthik will always do an 014.
I always want to learn from Karthik and Vishal. Always.
No, I mean, this case, Karthik, everybody is right.
Everybody's right. I agree.
So in this case, you could go either way.
PK, I just wanted to say, I mean, definitely you said this collateral doesn't matter. But I felt like this collateral matters of what you want to do. I think if you have already decided to stent it, I understand that. But if you're not deciding to stent it, this is an SFA to SFA collateral. If you see,
it's not. This collateral, it's not. Look at the runoff. The runoff shows
the other collateral is more significant than this.
The profunda collateral comes to the P1 segment, but this collateral forms gives you the Hunter canal segment. If you look at it.
But
both.
Even if you close this, the distal collateral will fill the
No, that's true. That's what I'm saying. But if you're planning to just do a DCB,
it doesn't. No,
I think it doesn't. This one doesn't.
Okay. We love to argue with.
But you're right. I mean, is the common thought process is correct to save the collateral?
When I see that big of a collateral, I prefer not to lose it.
Yes.
So.
No, that's what I'm saying. The thought process is correct.
With you, but I mean, if you look at this cap, can you show the cap again? If you balloon angioplasty that cap, you're going to lose the collateral, even if you DCB it.
You think so, PK?
I think so.
Okay.
I think you have so much plaque in that cap that you're going to lose that collateral. Your potential is very high. It's sort of like the coronary situation. Look at the size of that. Look where you're going to balloon angioplasty.
Yeah. Right.
It'll be a delayed filling collateral.
So what do you think is the reason you may perf here? Because I agree with you, because I think that,
It'll go into the
this, we
smaller.
may
The
be in a
re-
collateral here.
Yeah, the reason I think we might perf is I don't know if this is really the cap. I mean,
Correct.
it is possibly the
Exactly.
cap, but I just don't know this is a cap or not. Because
What's
it's
it
a
called?
very blunt cap, so it's possible this is a cap. I mean, that's the only thing we have option as to try.
Right.
But I think
That
there might be a completely separate cap. This might be completely a flush occlusion.
So I think that's where Karthik's point is great. So if you're not sure if it's a collateral, it's a cap, it's an underfilled segment of the SFA, then go with an 014. The harm done is much less as compared to going to an 035 and then dissecting and hematoma and you're in the muscle or wherever. So an 014 won't cause you as much trauma
Oh, that's not
if you're
bad.
not sure.
Okay.
You like
No,
you
it's-
like that?
No.
I don't know. I mean, probably take a different angle and say, I think you slipped into the big collateral, but
Yeah.
Now it's correct.
now it's
Yeah.
correct, definitely.
Yes, that's it.
That's better. That looks very favorable, right?
See, but this is the poo-poo that you go through with an 0-4.
Yeah,
You
yeah,
see this?
yeah.
This
No,
is
but
such
if you-
poo-poo right now. This is
Confident.
like, I'm not joking.
if
This
you-
is so annoying.
If you
Who said that?
if you
PK might-
continue,
Yeah,
PK, I just
No,
wanted to say,
I know. I agree with you. I'm just saying I adjusted it, but look. The damn. See, now I loop again, man. You know,
Yeah.
give me my.
There you go.
Give me my straight.
PK, I would,
So,
I would
I-
definitely show my son this recording because you have said poo poo a lot of times in this recording. So
We can-
he would love to hear that word. So
we can actually say now everyone was right, because now we identified that the proximal cap, the real proximal cap,
Yeah.
with the 014 wire, and now we're gonna go with the 035.
Everybody's happy.
Everybody is right.
Oh my God, you guys. No, but so anyway, so this is important. So I think these are great points. As much fun as we're having, this is a great point. And see, the reason I decided to go with the straight is, it looks like we're in the right spot,
Correct.
and we lost our pressure. Why did we lose our pressure?
Yeah, because
Oh, because we took it out. Okay. Flush forward, Michelle.
Mhm.
Give me a syringe.
Aspirate back.
Sorry about that, guys. A little technical issue here. Got some clots.
so Sardar, just to
Yeah.
let's continue our discussion here. But when would you go for a retrograde access here?
See?
I mean, in this case, initially I thought that the proximal cap doesn't look favorable, but doing the extra high MAC pictures showed that the proximal cap is actually very favorable. I would never actually start with retrograde. I will always have an antegrade access, because even if I go retrograde, I would just do it for the sake of crossing, and but the procedure will be completed from the antegrade access.
Right.
So, if in case
Then
I
it comes
escalate the
from the
wires
other
and
side?
don't
Yeah,
find
my
into the cap
little
and not
room
able to cross, I might escalate towards a pedal access, or maybe in this case also distal SFA access.
Distal SFA access
Might also be an option.
That's a good option.
That's
And
a good.
then-
Yeah, it's true. We never talked about distal SFA.
Distal SFA also. Yeah.
Well, nowadays when we have this pedal access, then I don't know how much distal SFA access you really want to get in through the thigh with the pain and everything. I think you can cross through retrogradely and then work up and over, so that way you can save your distal SFA access. I would probably
Vishal, would you use a primary pedal access here?
Okay, give me.
no.
Give me.
I mean, not really,
angle
unless we
glide.
don't have to.
Angle
Angle
glide.
glide. So the
PK,
straight glide.
Vicky, I know if you take the same 014 wire, I know you said it made a big loop and everything.
Okay,
But if you take a,
Give me a
yeah,
country answer.
but
No, no, we
instead of
have it.
using instead of using 035 catheter, right? If you use an angled 014 catheter and go forward with it, right? Do you don't think that will be a good idea to do it? Your
But,
trackability
you
will
know-
be better. There's some calcification.
No, the trackability is good. I can definitely push it. I agree with you. If there's no trackability, we could do that. But for me, the point is, like, I always tell the fellows, is the juice worth the squeeze, right? Like, what are we doing here? We just want to connect the dots here. There's no data that shows that intraluminal is better than not being intraluminal.
That's
There's no
true.
data that
That's
shows
true.
anything. For me, time is important and safety is important. So at safety first, obviously. So in this particular case, if the way we're going, I think it's more important. See, we're in a bad spot here.
We're in a bad
So I'm just
spot,
going to
yeah.
rotate the catheter. But I think that's very important here. To really
So I'm
decide
saying,
where we're going.
if you
Branch.
why don't you restart your loop on the top,
Yes.
PK?
I agree.
And then
I agree.
yeah.
Okay.
So I knew you will say time is important. That's what I was trying to get to. Is so because you're talking about pedal access here. So a lot of people who are watching it might be
Okay, right in the
thinking,
calcium. Fine.
you know, I'm not going to spend I'm not going to spend so much time trying to do antigrade. If I go pedal, I might be able to cross this in probably a couple of minutes.
Well, it's in the.
Really? I doubt it. Not with this much calcium. I don't agree with
That's
that.
what that I'm trying to be devil's advocate here. That's what I'm thinking. A lot of audience will be thinking who practice pedals. They always think people who practice pedals always think it's much easier to cross pedally than antigrade. What do you think about yourself?
Yeah.
I think it's if you do enough of CTOs, you might choose the pedal access as your alternative access. But I think completing this procedure from pedal is just unsafe for the pedal arteries. I would use the hybrid approach and start antigrade, and if I escalate and we are not successful, definitely for the sake of crossing, get a pedal access and try to cross. Once I cross, I switch back to antigrade access and snare the wire out and floss it out, and then complete the procedure from antigrade.
Give me the Terumo M wire. Now I'm going to switch to an 018.
Terumo Gold.
You can always go back up and restart.
PK, how long would you give before you switch to a retrograde access?
Probably 20 minutes.
Okay. How much do you use?
I mean, it all depends on.
All depends on progress.
It's very hard to say. I wire 20 minutes and then I just change.
I agree.
It's very very frequent. You have a feeling due to your experience whether you're gonna be successful with one or the other wire. Then you escalate the wires, and finally, if it might happen after 5 minutes that you say, okay, I'm done with my antigrade alphabet, and now I'm getting retrograde access. This might also take you up to 25-30 minutes, and then, but definitely for the sake of the radiation safety for the patient on your team, you can you should escalate to an retrograde access. Definitely not more than 25-30 minutes.
Vishal, do you switch quickly or?
Well, it depends when you get frustrated. I guess that's the right answer. So, but yeah, I mean, if you lose all your options, your wires, you created a big subintimal dissection plane, hematoma, you're not able to enter, then you just like switch over. But I don't think there's a timeline. It's just when you start thinking, you're losing a battle.
There is a question from the audience regarding the selection of the 018 Terumo M wire. Dr. Krishnan?
Yep.
What was your reason for selecting this wire? Was asked from one of our watchers.
Just experience. I mean, to me, I think this wire, you can see it's torqueable. It gives you enough body. And now I'm going to switch to a Terumo Navicross because you can see the heavy calcium we're dissecting all the way down. So give me a Terumo Navicross, and I'm going to go down with a Navicross.
PK, you think the direction of the Terumo M is good?
I think right now it's acceptable. So what you're doing is you can see you're in the calcific plane, and that's part of the reason why I felt like 035 would be better, because you are going to get subintimal in this kind of lesions. But I think at this stage you're close enough to the cap where if we, like Raman was talking earlier about using a re-entry device to demonstrate that, I think it all actually may work. But let's see. Let's get close. Navicross, please.
I think it's an RAO view as well, so just to keep that in mind. So
yeah.
I don't know if you can see, but yeah. But it looks favorable next to the calcium. We're subintimal.
Yeah, so give me a roadmap.
Yeah. Hold on. Okay, go.
So I think the wire was swirling around the whole calcified cap. So
exactly, and that's what happens, And if you get a little perf, don't worry about it. I mean, it's not a big deal. See, we're heading kind of toward it. You can see the wires heading toward it, so that's normal. And you're just gonna have to deal with it. I mean, this is a situation where you'd like to get in, and once you cross, we'll talk about algorithm of what we do. So right now, while I'm working, I'm asking our AB team to put this on the side, and I want Raman to go over this nice lecture that he's prepared, talking a little bit about everything that we've talked. And Raman, I want you to stop right before treatment.
All right.
Okay? Great, I got wire. Go ahead.
Hold on one second.
Can you put up Dr. Sharma's lecture, please?
Good, I got it.
You got that?
There you go.
Okay, so next slide. So as we were talking about, as Dr. Gujra had mentioned, there are different calcifications and morphologies of the proximal distal cap that become very relevant as far as describing the amount of that can help guide what approach would be best suitable And you see on the bottom left the 4 different diagrams, 1, 2, 3, 4, from left to right, showing the concave and convex entry and distal caps, and each of them, as you go from 1 to 4, demonstrates an increasing overall complexity, where the type 1 and 2 could be fixed, and a successful procedure could be accomplished by just a traditional either contralateral or antegrade access, versus 3 and 4, just by the nature of the proximal distal caps, may require a retrograde access to achieve success. Because as you can imagine, when the proximal cap is not very favorable, it's very easy to not it's very easy to have a very challenging time engaging the proximal cap, and always going off into collaterals if there are many significant side branches,
I think it's true.
and never really ultimately entering even the subintimal space. So again, all these, the ones in which we've been discussing for whether or not a hybrid approach with an antegrade and a retrograde access would be appropriate would be a type 3 or type 4. Next slide, please. So this is one of the previously published algorithms for how to intervene upon CTOs. That was developed by the PCTO group and presented at TCT. And it kind of does, it kind of demonstrates a similar treatment algorithm than we have all discussed, but everybody has had somewhat of a different opinion as far as how to really proceed. And I think the one real main takeaway from here is that there is no gold standard as far as how to really do this, but as long as you have a systematic approach and you continue to try to assess what would be the best as far as the best access point for each particular lesion based off the proximal cap, whether it's blunt or ambiguous, what is the length of the actual the CTO segment, do you have a good target vessel? And then the question would be, which would be the best way to really go? And in this particular group, they had a characteristics of 4 things, which was either a blunt ambiguous proximal cap or a type 4 CTOP classification CTO lesion, as well as a suboptimal target vessel, appropriate distal vessel access, and a CLI patient. So in this particular approach, they had suggested that a retrograde access would have allowed them a good amount of success in the procedure. And again, the retrograde access also then requires, true lumen puncture of the distal vessel, and then again your possible need for your more advanced cart and reverse cart therapies to then complete the actual procedure. Next slide, please. So we have a lot of re-entry devices available in the market. We have the Outback and Pioneer, which are the 2 main ones that we use here in this institution. The Outback is a re-entry device that works off a fluoroscopic guidance with 2 configurations of a distal fluoroscopic marker that in one view should be an L, and then in an orthogonal 90-degree view from that view should be a T configuration. And then there is a 7mm needle that can be advanced to gain entry into the true lumen. Pioneer is a very similar concept, except this uses a IVUS guided design that allows you to actually orient the true lumen that you're trying to gain access to, rotate your device to 12 o'clock, and then where you find the pulsatility of the actual vessel, that's where is the true lumen. And by a marking system on the actual IVUS, you can gauge directly how much you have to advance your needle to gain access to it. The N-tier is another flat balloon that has a needle that is directed towards the true lumen. And the off-road is another similar re-entry device that we particularly here don't use as often. But again, it's a conical balloon that, when it's inflated, has a distal part of it, lean in towards the true lumen. Next slide. So this group published a paper in the Korean Circulation Journal that kind of looked at what was the utility of using manual reentry versus a reentry device in all these CTOs. And one real simple takeaway is that success happened regardless. The difference was that what it really did affect was the amount of time needed on the procedure, the fluoro time, the time of actual reentry, and contrast use with the reentry devices. And that's really important to kind of take away when you're considering, as these procedures, some of them can be very, very complex. What is the true harm to the patient, as and using all the contrast and all the extra fluoro time. So it's something to definitely keep in the back of your mind. They also had another analysis looking at the Outback versus the Pioneer reentry system, and again, both of them did quite similarly. But the main difference was that the Pioneer group, again, to keep in mind, this is quite a small registry of patients. The Pioneer group had a little bit of a less time required for reentry, but again, with IVA's guidance, it does make the procedure somewhat more manageable. Next slide. Finally, we can be talking about some crossing catheters. We have a lot of these catheters once you're within the true lumen. And basically, there's a kind of ways to just grind through the true lumen, whatever it is that may be causing the actual obstruction. The one that most commonly used here is actually the laser made by Spectranetics, and this basically has pulses of the ultraviolet light to basically just either ablate all of the calcium and to allow for forward progress through very challenging and heavily calcified CTO segments. Next slide. All right.
Pioneer, do we have Pioneer? We should have one.
Continue on to the therapies, or?
No, this is good.
Yeah.
So right now you can see that I want you guys to see the staining. I don't want you to get scared of that. I mean, it is a CTO. We're in the dissection plane, and it's funny. I don't know why we've gotten so much staining, which is kind of interesting. So at this stage, what I want you to do is to say to yourself, okay, now we're not able to get through, and now I'm going to go ahead and do something else rather than keep trying the same thing. So it's been 10 minutes of wiring. For me, it's a claudicant. I don't have any reason to go pedal access, very diseased distal vessels. So I am going to go with a reentry device that we decided. Give me a particle wire, Chief. So what I'm going to go here is go with an Outback, which I prefer the Pioneer here because of the calcification, and I think we're on top of the vessel, but I like my current position a lot better than I like my last position. You see how the wire, how my catheter is more parallel to the vessel?
No, Spartacore.
Spartacore. So therefore, that will help me to be very clear in terms of how I'm going to enter. So go ahead.
Dr. Krishnan, a question. Just for the audience who were watching while Raman was giving his presentation, you changed for 035, 018, and then I believe there was a Confianza wire as well, or?
Yeah, I tried a Confianza because I felt Vishal and I were looking at the vessel. We felt we were on top of the vessel initially, so we thought we could pierce down. But clearly here we're on the side of the vessel right there. See, that's pretty good right there. I'm happy there. So I'm going to walk this back, and then I'm going to go with the Outback catheter. The nice thing is we have a nice favorable arch. The Pioneer would be better for us, in my opinion, because the ultrasound would help us because we're pretty much above the vessel, I believe.
And also it's a big vessel, so you might get a good color flow into that vessel. So.
Exactly. Totally agree. But unfortunately, we don't have one on the shelf. We've been doing a couple of deep venous arterializations over the last couple of days, and we've used a lot of the Pioneer catheters. So we don't have any Pioneer catheters on the shelf. So right now we're going to go with the Outback, and we'll see what we can do. Damien is going to be kind enough to ask one of our techs to check in radiology if they have a Pioneer catheter for us. Okay, they're looking downstairs. So as we speak, in case the needle is not going to be long enough to pierce the calcified cap. So now I'm going to go with this catheter. We're always going to have resistance as we let go of the wire a little, please. As we go over the arch, perfect. So you always want to let go of the wire a little bit as the operator tells you to. You want to get it down there. I don't know if it's going to go. Let's see. It doesn't seem to want to go.
Yeah, you might have to balloon the track.
Might have to balloon the track. I was hoping that the 035 wire catheter went.
I think it's because of that calcium in the mid
yes,
segment
I agree, buddy. I agree. Yep, and we're going to destroy this. So walk this out. Damien, give me a 4-0 balloon, buddy.
So you think you're right on top of the vessel?
I think so. I mean, it looks suspiciously close to that. So we're going to go with a 40014 balloon, and then we'll go ahead and balloon it, and then we'll do it. So right now we've turned off the Angiomax, and just to see while we balloon and see where we are.
Okay, now you should have it.
Okay, make sure.
Yeah, I mean that's the biggest issue is with these re-entry devices.
400 is fine.
That
This is actually a very good case to see how challenging it can be to cross and to.
So PK,
put
your PT segment, your posterior tibial segment is a very short segment, right, of CTO. So you don't think if you access the PT and go from below, I'm pretty sure we can cross the PT much easy, and because it's a CTO segment anyways, you don't think that will be a good idea to cross it from below?
I mean, I'm not saying it's a bad idea. I just feel that you're treating this guy as a claudican, right? And I think to cross to 2 CTOs to treat a claudican when you can open an Outback catheter and be done with it. These catheters are now very cheap. We're getting the Outback quite cheap now, and the Pioneer very cheap. So I don't think it's that much of an expense that you're adding to this case.
Okay. So only that staining is a little concerning. I don't know why the staining
is concerning.
I don't know why there is so much staining at that point though. That's after the distal cap. So
yeah, because it's tracking down. That's all.
It's tracking down. No. Yes.
Okay, let's go up here. Show me off-road map here.
Off-road map. So Karthik, why not the 80?
Okay.
Because
the only reason is because he's a claudicant. So I don't think we need to destroy a vessel which he regularly. It's.
Let's go up here.
If you do a sheethless, like we usually do with a support catheter, and we get access to the AT, I don't think we'll cause enough trauma just to cross it. And then, like I said, you can work from the top, snare, whatever you want to do. But crossing.
The only thing is there is so much calcification here. You have to really. There needs a lot of pushability on the catheter. So when you're pushing the catheter back and forth, you can cause a lot of spasm in the vessel itself. So I just feel like there is no reason to take a chance with the vessel he has, which is not a regular vessel. It's his AT is disease too. So, so I think the PT segment is very short and favorable for us to go through. So, but again, 14. As PK said, he's a claudicant, so there is no reason to cross 2 CTOs. That's a reasonable option.
Little down.
It's what chance do you want to take with it? That's a question, and it looks like it's a nice channel we created there.
It's just a dissection. That's all.
It's just
yeah.
Okay, let's walk it down. Just walk it out.
Yeah.
Is there a Pioneer available or no?
No.
Is there a Pioneer available or no? I thought we had one. He said we had another one.
Yeah, because we had one for the next case.
But there isn't.
Who used for last night?
So
yeah, I was here Monday.
Yeah, no, but we had one for the next case.
For this reason.
I think Outback should be fine, PK, because the tracking looks like.
I'm sure it is, but I'm just saying that I don't understand why when we thought we had one, we don't have one.
It happens when you do. We are doing a lot of cases after COVID, especially critical limbs. So I'm sure we ran out of equipment, and because of the COVID, I'm sure the hospital is not getting a lot of equipment coming in. So
that's true.
That's true.
I think it's a national problem. Everybody's facing it. So.
Let go a little bit.
It's a new normal, so we have to get used to it. So
good, fix it there.
Even though we pride in Mount Sinai that we have everything on the shelf, it's a new normal. I think we have to take
Damien, give me a new spot record. Just keep it on.
No, I need a fielder.
Oh, he wants a fielder. All right, so I remember
Dr.
somebody
Krishnan,
asking me. Yeah, sorry.
I think so.
You exchange now. You want to exchange for a fielder, just for the audience. Why did you exchange for a fielder rather than Spartaco?
Just to cross.
Okay, so somebody asked me this question, which I guess does make sense. So if you're using fielder, which is a hydrophilic coated wire through a needle, would you not share the coating off? I mean, that's the normal thought process.
I think definitely you're right. You can, but I feel that the fielder is able to get through some dissection planes that you might have created.
So PK, if you don't mind, Sardar will probably start going over the Outback technique you're using while you're trying. You want to go over?
No, actually, so Dr. Krishnan placed the outback catheter. He took the Spartacore wire out, exchanged it for now, and then he pulled out the needle. If you see it, it's on the right side of the screen, next to a little bit above the L radiopaque marker. Now you see the wire coming out of the needle. Looks like could be short.
So PK, so when you are getting in with the needle, normally you want to be in a T shape to the vessel. Then you turn it to an L shape, and then you start releasing your needle in. So I think PK already knows which direction the vessel is in. Normally, what you have to do is you have to put it in a T shape like this and take a picture in two angles. In one angle, it has to be T. In the other angle, it has to be L. The angle which has to be L is the angle which is right on top of the vessel or parallel to the vessel. So I think PK already knows which direction the vessel is in, but so now he's changed it to an RAO view
for the teaching purpose.
for the teaching purposes. I think he's doing it.
Inject.
Well, for me, I'm a little concerned because I'm trying to figure out where that vessel is exactly.
So it's on
And
the
you
other
see,
side.
we're on the side of the vessel. We still have to come
Right.
down further.
Yes. So
So-
that's also one thing.
So what
So-
I'm going to do is I'm just going to push this down. And I think
So no-
Sardar is right. We're quite far away,
Yeah.
which is going to be an issue for us in terms of our ability to
No, we just have to be in the normal.
advance the needle in.
The needle, yeah.
Yeah. So
That's why
this is
I was kind of asking for that outback because I felt we were on top of the vessel.
if I'm not wrong,
So-
PK, this is an RAO view, right?
There's
Yeah.
an RAO view.
So you have to be T on this RAO view, and then you go to
Correct.
LAO and then be an L, right?
Right. Oh, you're following their teaching.
Yeah.
Yeah.
Okay. Yeah. I just
So I think
So
for
you
me the biggest thing is
Yeah,
we
not
have to be
reaching.
next to the normal segment
not reaching.
of the vessel. So if you
Yeah,
really
exactly.
see, if you
So I
enter
think
in
we
the
have to
disease
come a little bit
segment,
more
yeah,
distally, PK.
That's
No,
what
I agree with you. I agree with you. I'm just trying to enter a little bit above here.
There.
Right. Just go a little bit more above.
No. that's
Perfect.
Perfect.
So that's
That
a good
looks
spot. So now you have to be T here and then go to LAO and become an L, right?
Or anything, you just have to be orthogonal
Yeah,
in two
it's-
views where it shows you're on top of the vessel and towards it.
No, we're too far away, guys. We're definitely too far away.
Because we are an RAO view, you want to go LAO and take a picture, PK?
Go LA
Yeah.
now.
Watch your light.
So you'll be
Okay,
T here now, right?
little
So
dot.
that's why.
Mm-hmm.
So
You have to just rotate to make it a T.
yes.
Yeah.
So now you have to make an L here on a ipsilateral view.
T.
You have to become an L. L.
No, I'm too far away. See?
Yeah.
I'm way too far away. So, guys, we need an outback somehow. Somewhere along the line, we need an outback.
Pioneer.
Pioneer.
Pioneer. PK, if you dissect the vessel a little bit more down, you might get closer
Yes.
right on top
That's
of the
what I'm
vessel.
going to do. So, give me
Yeah.
a catheter, guys.
Because the major
me a-
collateral is coming to the P1
wire.
segment
Give me
anyways.
the, what is it called? The, no. Give me the Spartacore. Oh, you can push this down and give me the
Hold on, where's my
the Terumo Navicross. That's fine. Leave it there.
Yeah.
Let's see if we can dissect a little closer. I don't think we. Let's see.
Yeah, I think with the
Little
device
dot,
also
little
you
dot.
can do it, PK.
Little dot. Yeah, I agree with you. I just want to see
Yeah, with the-
how close we're getting.
It'll go because
Yeah, you'll get
it
pretty
has a
close
good
with the
far
device.
away. You see that? Too far away.
I think
but
that's,
still,
uh,
you're still within the 5 centimeter range.
No, that's too far, dude. Don't you think?
Just try. I
you,
think.
why don't you try it, PK?
Yeah.
And see?
Rail.
Well,
This is the Truman Gold.
no,
Yeah.
hold on.
No, he doesn't.
There
want
it
this.
is.
This-
Yeah, there you go. Now that's better.
Oh,
Not
got
going. You're not railing.
I am.
No, you're not.
Hold on. Okay. You just have to torque it. I'll give you a real.
Needle's back.
Yeah, needle is back.
Needle's back is not going. Hold on.
I think you got
Oh,
it.
don't
You
pull the
just-
wire. Don't pull the
I'm
wire.
not, I'm
you
not.
are.
Okay, fair. Wire is all the way.
I think you got through.
No, he's not.
I have the rail. See,
Yeah,
it
yeah.
keeps coming back.
No, you have to walk this out. Now.
Yeah.
Let's walk it out and get us. Let's try again. No, rail it for me properly.
Yeah.
Let me see the device. See, there's no tension on the wire, Vishal. See, the wire didn't have any tension on it.
So
Because the wire was coming back, that's why I didn't want to lose hair.
already.
Do we have a device or no? Can you call Mike Wallace? All right. Let me give me this now. All right.
Just flush it again.
You think it's far away for an outback, PK?
100%.
Yeah.
Yeah.
It's too
Alright,
far.
I have the wire.
That's why I'm going to have to redissect.
I have the wire.
Real? Okay.
Go.
Let's go. See how the wire is bending again?
I know, because it's a
The
little
wire's back,
feed.
which is fine. Let it come back. This is a big truck of a hole now, so it's no big deal.
Yeah. Yeah.
Okay. All right. Now give me a Terumo 018 Gold. No, we have it.
Yeah, the one we just had. Right there.
Make it wet.
Yeah, still.
So distal SFA access, Sardar, let's talk about it. I know we talked about pedals and everything. When would you prefer to go distal SFA access?
I mean, that's the second alternative access we can use. In this case, actually looks like it's favorable
Right.
to use it.
Especially if you have the Hunter Canal open.
Open, yeah,
Yes.
exactly.
Liz, is he in any pain?
Look like so. He didn't even clinch a bit. His leg doesn't even move. So.
Huh? Okay. Okay, now let me have.
You want a little bit of test to see how? Oh, yeah.
See how wide we are moving now?
Yeah.
Yeah, it's
What
a
do
big
you-
plane we created, which is expected, right? Because it's a big vessel
No,
also.
I'm
so-
not
after
denying
the-
that, little
Yeah.
guy.
See, you're on.
That's pretty good. Yeah, you're in, PK. You might be
Yeah.
in,
No,
so.
I'm not in. I wish.
No, you're close, but you're
But you're
close
very
here.
close, though.
Yeah, you're right on top
Nope,
of it.
nope. I'm right
I mean,
on.
I know you're around it, but the outback should work there. We just have to
Yeah.
go.
The needle itself, the Outback has a 7 millimeters.
Yeah.
So definitely closer than you were when you were
Hold on
at
a
a
second.
25.
First, let's put us
The
on
core calf
regular
one.
fluoro.
Yeah, got it.
Right.
You can do regular.
Okay.
So
Now
now?
let's mag up. Okay, ready to roadmap?
Roadmap it is.
Go. Okay, now give me a confianza wire now. We have one, guys.
Yeah, that's probably right on top of the vessel. It behaves like it's right on top of the vessel.
What the tip
Agreed.
look like?
Especially with the angle I'm coming in.
Yeah,
that's
it's
the
especially
command.
with the angle you're coming in. Yeah, this might be a
Yep.
good spot to go out back,
Yeah.
PK.
I'm not quite next to the vessel yet. That's the thing. Okay, so give me this. Hold this.
So it's a big vessel also. It's a really big vessel, so all you have to do is just touch it and I think you'll get in. It's a clean spot too, so
I think you're in.
No, I'm not.
it's about the level of the collateral. No, he's definitely not. But I think
What up?
the way it behaves,
All
it's
right.
very subintimal, right on top of the vessel.
It's one of those things with the Outback. It's that if you're not right next to the vessel, it's not going to work.
Yeah.
So that's why
It
initially
bounces off of the vessel.
Yeah, I wanted the Pioneer because I felt the Pioneer would be a better situation for us to be able to find the vessel and go in. But of course, you never have anything when you need you. But it's a good opportunity to see the different techniques of getting in.
Yeah.
So right now, I am not going to take any more chances here with this. If this does not go, then I am going to go ahead and
Rather.
get either pedal access, but since we don't have a Pioneer, or get direct SFA access. Likely pedal though.
PK, you want to try outback once here and see?
Yeah, I would.
I
Because
wouldn't
it looks
because
like it's
now.
okay.
No.
I think
no,
yeah.
we're not nope. We're
Right
on
there
top.
side. Well, so that's why outback. Oh, there. No.
No. We are dissecting the vessel on top of the
So
vessel.
here, if you're really on top, I think it should work.
Yeah.
I mean, again.
PK, you want to take an RA view again,
Alright.
and see how far you are?
Okay, there's no point.
No, it's
So I think
not.
if you just take a
It's right on
catheter
top of
down
the vessel.
outback there, you'll be successful.
What's that?
If you,
No,
there's no pioneer.
see, you also have to understand that I'm now distal to the point where I don't want to be
Correct.
near getting
Right.
into the distal pop.
This will
So
pop.
right
That's
now,
right.
right now, I am close to the popliteal.
Yeah,
which is
P1
kinda-
segment.
My segment
Right.
of occlusion reentry was
extended.
supposed to be right here. This is where
Right.
I wanted to
That's-
reenter.
that's right.
So
True.
therefore, if I go distal to this, I'm going to continue to dissect down, which I
That's
don't
right.
want to do.
Yep.
So I would much
Agreed.
rather try to go with another device or another access to try to get through, and I'm still not through. See, you can tell this is so
Yeah, you're just
calcified.
going, yeah, and you created a big plane also, PK. So you're just swirling
Yeah.
around the vessel in all different directions. So
Yep.
yeah,
So the only thing we could do is possibly get close, and like Vishal said, keep our zone at this level,
yep,
and
agreed.
then try to use the
Right.
outback here
Yeah,
Exactly.
because we're right on top of the vessel. But
yeah,
give me a 035 wire now. I just want to get this catheter a little bit closer to the vessel, just above the collateral, and then I'm going to try.
PK, so there is a big segment there, which was almost like hibernating vessel, right? So you
Yep.
don't think you're
You'll be
close
straight.
enough?
No, straight.
You want to go a
Yeah.
little bit more closer?
I mean, we could try. We could try
But
this
I
time.
think
But
you're
remember,
close enough, right? I just don't want to go close to that huge collateral.
The huge color.
I agree with you. But I think in this situation, you've created, because of the balloon angioplasty in the subintimal plane, you have not
Right.
closed that vessel.
Right.
So
True.
you need to get intraluminal to try to get through, right? So that's what I'm a little concerned about. So since you've closed that vessel with an angioplasty, you need to now get close to the vessel to be able to do the outback. So now we know we're on top of the vessel. Now I'm going to take an 014 wire,
Give me the Spartacore again.
Spartacore, make sure the outback is not broken.
Flush.
And Vishal, we want you to rail the wire.
Yes,
Well-
please.
So I'll be off the
rail, yeah.
camera to tell you what happened.
Please,
No, it's not true though.
please.
Everything is recorded.
Everything is recorded here.
Whatever you say could and can be used against you. So I don't want to use anything right now.
Yeah.
I thought the only one who says I'm a grouch is Elizabeth. I didn't know that everybody else does too. Okay. Yeah, that's good right there. It's Vishal didn't have breakfast today, so he's a little weak. We
No,
love to
Vishal
pick
is
on
Vishal is actually a little bit on the crankier side also today.
He
so-
is. I noticed
Yes,
that.
I think so
I noticed that too.
I can
I
guarantee
noticed
you he
that
didn't
too.
have his coffee also. So
I noticed that too.
What is wrong with
And he,
people?
and he wanted this case to be done very quickly.
yeah, Vishal needs his coffee and a little bit of dessert early in the morning. So
So I don't understand. Why don't we have a Pioneer or an Outback? This is interesting. Mount Sinai Cath Lab has one device. Can you call Kurt? Let's ask Kurt online
sorry.
what he thinks.
It's just-
No, but
Yeah.
we should ask him online so the audience also can know. Informing
microphones
minds
right
want to
there.
know,
I
right?
mean, I think the audience knows that it's a UPS fault, so USPS fault. They're saying that
Watch the wire.
we're getting
From it.
emails, PK, saying that it's
Oh,
probably
no,
the
no, let go,
USPS
let
and
go,
the
let go,
FedEx
let
is
go,
the
let
reason.
One second.
Okay, good. Fix it now.
Yeah, let go.
Yeah.
You like the rail, PK?
Oh,
You like the rail, PK?
he's mad at me.
You like the rail,
Karthik.
PK?
Karthik, he's mad at me.
You like the rail?
That's
Lance?
the end of it.
I
He's
think
mad
that's a
at me.
good spot.
That's a little bit passive aggressive, yes.
I think this is a good way to show that even though we are going longer than actually we anticipated this case, I think it's still
have a new
acceptable to
fielder?
have fun during the case.
Oh my God. I don't know. I'm not having
Fielder.
I want to be having my coffee with Vishal.
So we're L in this configuration. Then do you want to go?
Damien, fielder.
Give me the field. So what I did was I just fired the needle on
Fielder.
the T. You can see it's off a little bit on the side. And then if this does not work, we'll give it a couple of
This
shots,
is
me and
trash.
Vishal. If it does not work, then we'll just go for a pedal access.
So there is Pioneer in the hospital. He's looking for it right
They
now.
are looking for it.
Yeah.
So we have the group in search of the Pioneer.
CSI, Mount Sinai.
Exactly. CSI Mount Sinai is working as we speak.
It's odd because we were supposed to have one.
Yeah,
in
exactly.
Vic. Yeah.
Yeah.
So Raman knew that we had a case today, which was a case of deep venous revascularization, and we needed the Pioneer. And obviously, thank God that case is not going on today. So again, we're on top of the vessel. You saw that
So I have to
curvature,
do those two.
right?
Yeah.
So I'm just going to pull back a little to see whether that works. Nope, it didn't work. So again, we're on the dissection plane.
Maybe
So now I'm going
Turn.
to try to turn a little bit more,
Make it an L
make a
shape.
T. Yeah,
make it a T. He wants me to. So
that's
I'll
good. A
listen to
little
him.
bit.
I told you he's missing his coffee.
I just told him. Huh?
Pioneer is here.
The Pioneer has arrived.
No, don't
Wow.
worry about it right now. Let's
All
try
right,
this
hold
for a
on.
little
Let's
bit.
try it now.
So remember, the calcification also bumps you off. See, I'm just not reaching the vessel. So let's go to another view.
Yep.
Okay, ready?
Ready. Oh, hold on. Oh,
Inject.
go.
So you have to be an L shape here and T in the other.
Yep.
There it is. Okay. So we okay. You're right, Karthik. We have got to get to an L, which we're going to do right
So
now.
yeah, see the RAOL and the
The other L.
other L.
Yeah.
The LL. That's
Yeah. It should be an L.
Yeah,
shape,
like
though.
your
and then when
PK,
you
like
go
your
orthogonal,
like,
you
like your
confirm
favorite.
that it's
It's
a T.
the L should be like your favorite sport, the golf club, and
Yeah.
yeah. Now I think you pierced it, PK.
That was
Yep.
good.
that's
Okay,
too
we're
far.
in.
All right,
So
hold
yeah.
on. Time out.
So we
Yep.
did the L shape there. We got through. So now we're going to walk this out. Now we're going to get to the treatment algorithm. Boy, I hope you guys are awake and well.
I mean, it's amazing, PK. You're such an avid golf player, and you still cannot put your L's and T's in proper shape. So
When do you put L and T in golf? I'm curious.
I
He's
don't know.
talking about putting.
Your
those-
putting and everything is not L. That's an L shape. I'm not a golf player, so I don't know. You keep saying that you
little
take us to
diagram?
golf, but you never took us
Yeah,
to
it's
golf.
perfect.
So
Don't worry about
Yeah,
it.
yeah.
It's in the PT now. It's good.
it's in the
yeah.
PT now, unless you want to cross the PT CTO. So
Yeah, we will
okay.
likely cross something. All right, guys. Now give
Perfect.
me a long 4-0 balloon.
perfect.
Perfect. Wonderful.
We don't need the
Yeah,
outback.
like a
Long
40,
4-0 balloon.
150, 200.
All right, so now let's put up Raman's slide. So I want to tell you what I'm going to do now. While Raman is going over the treatment options, we're going to go ahead and balloon angioplasty this to get the straight line flow to the foot. So Raman, go ahead, start. Let's put up the slides.
Okay.
And now give me a 4-0 long balloon.
So we're going to go about this systematically, kind of just overall the different types of treatment options that are available.
Yeah.
So the first, we're going to start by looking at DCBs versus just PTCA, and we know that the earliest trials did show a superiority of the DCB, the drug-coated balloons, over the PTA at 12 months in terms of primary patency as well as clinically driven target lesion revascularization. The IMPACT, which is looking at the IMPACT paclitaxel balloon, was a single-blind randomized controlled trial with 2-to-1 randomization with the DCB versus PTA group, and it showed that in a 12 months patency, the DCB arm had nearly an 80% patency compared to 50% patency to the PTA group, and very impressively low clinically driven target lesion revascularization at 9% versus nearly 30% in the PTA arm. The Levant 2, which is looking at the Lutonix balloon, was another study that was published in a New England journal. That was a little bit of a larger population, about 475 patients with symptomatic fem-pop disease, again a single-blind RCT that also looked at primary patency and the clinically driven target lesion revascularization. Showed a primary patency at 12 months of 65% versus PTA of 52%. So one takeaway at this point right here is just to notice that the PTA primary patency was similar between these two studies, except for the Lutonix balloon showed a little bit of a lower primary patency noted at 1 year compared to the IMPACT balloon. And all these studies did show that the primary safety endpoints were always met. There was nothing that was particularly significant that demonstrated an inferiority to PTA alone. But another very important point was that the Lutonix study did not show any change between the groups as far as the functional outcomes, death, amputation, thrombosis, but most importantly, the target lesion revascularization, which was so impressively seen in the IMPACT SFA study. Next slide. Next, we're going to look at bare metal stents versus PTA. We know that the bare metal stents clearly have a benefit over PTA, but the issue with bare metal stenting is the issue of restenosis. PTA alone is, it by itself has been seen in several studies to have target lesion revascularization of nearly 50%, as we saw in the the previous two studies in their control arms. But they have a priming patency rate depending on the severity of the disease and how complex the lesion is, of a patency rate of as low as 30% in 1 year. The resilient study was looking at the self-expanding life stent compared to just PTA. And what they saw was that there was a higher freedom of target lesion revascularization compared with the PTA group, 75% versus 41%, as well as an improvement in their Rutherford class. Now, the only complicated issue is that with the use of the bare metal stenting is that with these long stents and this self-expanding nature of it, there were actually high incidences or higher incidences of bare metal stenting developing stent fractures, and as well as high rates of ISR. A complication is something that we are constantly concerned about in this particular field. And this notion kind of began the new generation of self-expanding stents, the Supera, which is actually a woven nitinol stent, as opposed to the life stent, which is a laser cut. And this pretty much allows for more radial force and less kinking and stent fracturing of the actual stent. And this actually did show in the Superb study a very high priming patency rate of 85%, depending on the degrees of elongation noted in the highest, the best optimal deployment group with minimal elongation and minimal compression at 12 months of roughly 85%, and which persisted to 75% at 2 years. And again, no stent fractures, given the unique nature of how this woven nitinol stent is actually manufactured. Next slide. So then we're talking about balloon expandable stents, self-expandable stents. There are quite a few. The self-expanding are the Supera, the Absolute, Innova, Life Stent, Everflex, Smart. And then you have your drug-eluting stents that are self-expanding, like your Zilver, PTX, and your Illuvia. And your balloon expandables are your Palmas, Perflex, Strecker, your covered stents of your Wall and Joe stents, and your Viabonds. And one of the main things to kind of talk about is what these are really good for. The balloon expandable stents are really important and are really useful when you're trying to nail your osteal lesions, because with your self-expanding stents, there is a good amount of motion that can actually happen at the time of deployment, based off just the nature of how these stents are unsheathed. So balloon expandable stents are very important for that. They have a very high radial force, but because of that, they also are prone to fracture, as opposed to your self-expanding stents that are more flexible, have longer length, are kink resistant, but they have generally a lower radial force. And because of, again, this unsheathing deployment mechanism, they are less precise. Next slide. Next, we're going to look at bare metal stents versus the drug-eluting stents. The Sirocco was looking at the smart stents. That was one of the earlier studies that was comparing the Sirolimus self-expanding smart stent. And what was interesting about it was that the priming patency that was seen was still roughly in the 68-70%, which is a little bit lower than it was seen in the DCB arm of the impact and Lutonix arm. But the restenosis rates was actually surprisingly similar to the bare metal stenting group and the Sirolimus self-expanding stent group. One of the reasons why that's important to just take note of is that the restenosis rate of the bare metal group was surprisingly low, only about 8%, 7% or so. After this came the Zilver PTX trial that looked at symptomatic femoral popliteal disease, and it was a large group that was looking at all comers who were greater than Rutherford classification 2, as well as lesions that were less than 14%. And these basically compared PTA versus a PTA with PTA versus the paclitaxel Zilver stent. And this also had a secondary randomization as far as whether or not after PTA was there was another provisional stenting that was done afterwards as well. And what they found was that the Zilver was superior to PTA or provisional bare metal stenting in regards to primary patency, freedom for clinically different or all target lesion revascularization, and clinical benefit at 12 months. And again, it's important to take into account the secondary randomization that was also done that showed that there was a superiority to provisional Zilver PTX versus provisional bare metal stenting after a initial PTA. This is, again, keep note, this is in a smaller group of patients. So we can't extrapolate everything to it, but it's a very impressive difference. We see 83 versus 67% in this study. Next slide. Finally, now we're going to be looking at the at this final study that was looking at the DCB versus DES studies, and what we saw that in this group, there was a very large group of patients that had both claudication CLIs and had a good amount of lesions were actually CTOs. And what they found was that at 12 months, there was not a very significant difference in primary patency. But the primary patency in both these groups, in the DES and DCB, was very, very good, about 80%. At 3 years, when they started to follow these out, they saw that the DES had a slightly higher primary patency of 55% versus the 38% in the DCB arm. And there was this trend towards an improved outcome with the drug-eluting stents compared to the DCB arm at 36 months as well in regards to the primary patency and the target lesion revascularization, but these were non-significant. Next. The use of atherectomy is something that we do quite often, and we will, something that we have to consider is this directional atherectomy plus anti-restenotic therapy. And this group was looking at what the role of this was compared to just DCB alone. And this is just a meta-analysis that showed that there was no superiority of directional atherectomy plus anti-restenotic therapy compared to DCB alone. But this whole notion of leave nothing behind was kind of seen in this arm because there was no need for bailout stenting. But again, there's just a trend towards better patency and TLR with DART, but nothing that was clinically significant. Next slide. Finally, just a quick mention about directional atherectomy. The definitive LE study was a study that was comparing, that was looking at just directional atherectomy and PTA. And this particular slide is important just to kind of take a second and just look at what the patency that directional atherectomy resulted in. And in this particular study, going by the primary patency definition, which is a duplex definition of a PSVR of less than 2.4, which is generally accepted as a primary patency definition at 12 months, was surprisingly similar to all the studies involving bare metal stents, drug-eluting stents, and drug-eluting balloons. So just something just to kind of keep in the back of your mind when you're deciding what is your full algorithm that you're going to be choosing. Next slide. Finally, in regards to filters, we know that all these complicated cases, highly calcified, long lesion, CTOs, ISRs, they're all things that make us worry about distal embolization post the atherectomy. This is a nice algorithm that was put together showing that based off the type of lesion, the length of the lesion, putting in a filter before doing any of the atherectomy severely improves the outcomes of the patients and preventing distal embolization requiring extra intervention. Next slide. So that was a mouthful, but again, there's been a lot of treatment options that were discussed, and in the recent years, there have been a lot of different options, including bare metal stenting, drug-eluting stenting, balloons, directional atherectomy, but what we do know so far is that the drug-eluting stents has the best long-term data up to 5 years, and also seen at 2 years. And DCB is a very good alternative therapy with able to hopefully keep this notion of leave nothing behind. but their long-term data still needs to be determined as well. We have all these studies regarding the mortality issue with the paclitaxel. That is always an important conversation to have with the patients when you're consenting them for the procedures. And again, then there's the other plaque modification therapies that we always have to employ prior with a directional atherectomy or shockwave intravascular lithotripsy or et cetera. And then finally, the importance of filter use for these cases, especially those with CTOs, ISR, long lesions, will dramatically improve your overall results and outcomes. Oh, okay. And that's it. And that's a good picture.
That was actually a good presentation. I just didn't know whether did he touch on Alluvia? Because I think I missed it. Was the Imperial study mentioned?
No.
Okay, so the very important Imperial study was done. Was published in Lancet about I think a year and a half, 2 years ago now. Really showed it was a head-to-head comparison between the Boston Scientific Alluvia stent and the Silver PTX, which showed at 1 year superiority of the Alluvia stent over the Silver PTX. But at 2 years, their recent data showed there was no difference. However, interestingly, there was a trend towards decreased mortality in the Alluvia arm at 1 year. So interesting stuff, but I think that's an important one to also mention. So quickly, it's 9:20, which is not bad for a tough case, about an hour and 10 minutes. Karthik, what would your therapy be here?
I mean, we are totally in a dissection plane, PK. So I would probably go with the initial PTA and just DCB it. I think stenting it is not a bad idea at all. It's not a long segment. I think after you did the initial balloon, I saw it that your dissection plane was not too long enough. So I think the result, this is after PTA and DCB looks like, right?
Yep.
And this looks great to me. I mean, I would leave it like this. It's a short segment CTO. This is
Well,
more
it's
than
not short.
acceptable.
It's 200 millimeters. Vishal and I used it.
Normal to normal,
balloon.
yeah.
It's not
Yeah.
short.
But
By
this
every
looks like a
definition, it's long.
completely acceptable. There's some dissection, non-flow limiting. I think this is totally acceptable to me. For a claudication, great result.
Sardar?
What do you
It
think?
is. I mean, I agree. I mean, also scaffolding this dissection might be also an option to increase the patency by some percentage. But I think Karthik's approach with DCBing it and observing it for a claudicant is a good thing to do.
Vishal?
I think I agree with the panel. I mean, we have good outflow, good inflow. Dissection plane is well tacked in. We drugged it, and I think if we leave without putting a stent in, we can monitor him clinically and with the duplex, and then figure out if we have to do a secondary patency or anything.
So what about you, Raman? You review the literature for us. What do you think? First of all, literature-wise, what does it show? Has this lesion been studied in any of the studies that you quoted, or no?
Well, the one thing that's unique about this that's not really in the literature is how long it is. This is like roughly like as you had mentioned, about a 20 millimeter lesion. These
20 centimeter.
20 centimeters, yeah.
Right, 200.
Peripheral, not coronaries. And I think that's and as far as lesions like this that they have looked at retrospectively, as an overall patency in lesions this long, they tend to do better with stenting, just because of how long they are. So I think, albeit this a claudicant, and this is also a patient who this is, as mentioned, this is a very long dissection plane. I actually will play devil's advocate, and I think maybe putting in a long bare metal stent may actually improve the overall patency long term for him.
That's a good point. The couple of things. This lesion has not been studied in a randomized control fashion. Has been studied in the impact registry, long lesion registry, and in impact CTO. They're both retrospective. Actually, the prospective registries, which are core lab adjudicated, and both of them show that that stenting was occurred in 40% of the case. For me personally, I would stent the proximal area. If you look around 15 to 20, that's the area where you had recoil, and Vishal and I went up really high with the balloon. So what I'm going to do is I'm going to recommend that Vishal put a Supera at that level after vessel prep. So we're going to just stay here for the Supera deployment. Damien, give me a 6080 high pressure balloon,
Dorado.
please. Or give me a 7080 high pressure balloon.
7 Dorado.
So what we're going to do is this area is what I'm not happy with, right around 15 or what
to
it was.
17.
Well, it's probably a little bit less than that. So let's do a quick roadmap. So I think that, I agree with Karthik 100%. Everything else looks really, really pretty. But you see that area? That does not look pretty to me. So we're gonna balloon this with a 7. And then we're going to put a supera in here. Distally, I'm okay with that. It looks pretty good, and there's always a chance of perforation here, but we're going to go with a really big balloon because the 6.0 definitely did not work. So 7.0, please.
Just for the record, PK, the collateral stayed open. I don't think it matters, but
But the other collateral closed down. The one he was more concerned about going down.
Well, that's because we didn't enter at the level of the collateral. You're right.
Yes. We entered
7.0,
after
60.
760.
7-0.
What do you got?
7 or 100.
Not too big.
60, 40.
40.
60.
60.
60.
60.
No 60?
Yeah, 60.
What do you have? 40?
60. 60.
All right, 40 is fine. Give me a 40. Whatever you have.
No,
Balloon we can
Yeah,
use
take
again.
And then get me what do you think? 40 or 60 supera, Karthik?
80.
But if you
80?
Yeah.
You like 80?
No,
Yeah.
I think so because
that's a 40.
the
You have a 60.
lesion is longer than
Yeah,
around
it starts
60.
at 14 and goes down to
60,
20.
yeah.
So I
So
would
yeah,
go with
you
80.
have to. Well, I would probably go. You want to go above before the collateral?
Yeah, because you have a
No,
little
right
bump,
at the level of the collateral. Yeah.
You have a. He's not extended.
So you want to
either.
start from 20
I don't
all
want
the way
PK
to
to
14?
tell me the
It's just-
collateral is closed now. So
No, I agree with you. I
Just
don't.
kidding.
No, I know. I just think that. This is going to be interesting. Let's
So it
use
should
the
be an-
balloon. Let's use the balloon.
PK,
now
you,
first.
PK, you
it
want
should be
to
an
start?
80.
You want to
From
be
a
on air
12
for
to a
this?
20.
Yes.
Okay.
This is superior deployment. I think is incredibly important, and Vishal and you are a couple of the best in the world at it. So we will.
There it is.
We will
Karthik,
go ahead.
what length do you want on Supera?
I was just thinking, why didn't he still say it? He just said it. So
So let's see here.
I was feeling bad that he didn't call us the
Right
best
there.
during this procedure.
Right there.
So
It's
Right
okay.
there. Then we're going to go right here.
Go forward.
The problem is, as Sardar says, that hasn't been validated though. Let's go up.
what hasn't been validated? I'm sorry.
It's okay.
Actually, for us, you saying itself is a validation for us. So.
I'm joking. Come on.
6.
You gotta
Dr.
crack
Krishnan
it.
is the chief of endovascular system at Mount
Turn
Sinai.
off
So
roadmap.
Yeah.
he's saying itself is a validation for us. So we'll take it
Go.
as a validation process.
Because
No,
this is our world, right? Sinai is our world. So we are
breathe,
technically.
breathe. That's 40. I think 60 is more than enough. Okay, that's 40. We just got to go above 15.
No, but you want to start from 20, go till
About
12.
I think, yeah.
Okay.
All right. 20. What are you at?
10.
Keep going up.
Probably 80 and make it 70. Probably better.
What is that?
14.
No, I want to give it 80 and keep
Down.
it 80.
So now I've prepared the vessel, which is very important. Now I'm just going to walk it back to
Right.
right about there.
Yeah.
Exactly.
Go
yeah.
up. So this is about 60. Let's do a 60.
There is it.
So you might be saying, why am I using a 7.0? Because I'm planning on using a 5.5 in a very calcified vessel. So
PK, it's a big vessel, right? Why don't you use a 6.0?
No, I think 5.5 is good here because it's very calcified. We want to
Yeah.
get a nice lumen without elongation. I think 5.5 is good. You're at what?
Because
14.
even your
14.
see,
Down.
this is a 7.0 vessel going to 14, and even this looks.
No, but I think it's
I
not
would probably
expanding.
go with 6.0.
It's not expanding.
I don't think it's expanding.
I
That's
think
the
you
reason.
did. I think you did. I think you got a
No.
pretty reasonable expansion there.
I agree, but I think here, we're in the subintimal plane.
5.5 gives you a 5.0 lumen, so I don't know if.
Let's take a DSA.
Yeah, it is just.
I mean, you always can do an IVUS now and
Yeah,
size it.
I just feel like
but
it's a huge vessel, so it's
Yeah.
probably. I would probably go with 6 or 80. So
What do you think, Vishal?
6
6.080
should be
then.
680.
You know
Yeah.
what? I'm going to stick with my gut. 5.580.
5.580.
who's deploying it? You or PK? You or Vishal?
If
Who's
I
deploying
deployed it, I would deploy a 4.0.
If Vishal is deploying it, I think it's fine with to go with 6.0.
Let's go.
And Vishal likes the 5.5, right?
Yeah,
Yeah, I
Vishal's
like my
favorite
I like-
stand. Vishal's
I like
favorite
my
stand is
5x5.
5.5 Supera. So
Let's road map it, bro.
Yeah.
Ready?
Yep.
So I'm gonna let Vishal talk through the deployment here. So I think we prepped the vessel quite well, but I'm still worried around 19. So Vishal's gonna probably start the stent around 20 and then
20.
extend it up, and
Yeah.
then Karthik, can you talk a little bit about
Flush.
post dilating the stent, whether it's even possible?
So I mean, if you're putting a 5.5, I mean, I would recommendation for Supera is there is no need for post dilatation because it's a self-expanding nitinol stent, Again, it's a has a great radial strength. So the radial force is so good. I don't think you're going to achieve anything. If you have not expanded a superior stent, I think you have already caused a mal-deployment there.
Off
But
program.
Yeah.
So, yep,
putting
sorry.
all things aside,
Yeah.
just based
Go
on
ahead.
clinical
Go down, go
experience, I always post dilate my supera. I always feel like you can get a little bit of more lumen by post dilatation in unexpanded areas.
So you're still on a
I don't
higher
know
up.
what Sardar
Back
and
there.
PK and Vishal think about it, but if it was a 6.0, I would have definitely not post dilated, but it's 5.5.
Yeah.
So I would definitely go with a little bit of post dilatation.
Around 20 is good, bro.
20.
What do you think?
Right
I
there.
mean, I think if
You want
you
it right there?
if
You're
you
gonna come 11.
anticipate
Just to
a
catch.
recoiled
Yeah.
section, you can actually stack
Yeah.
the supera there.
Yeah.
So by then you gain a little bit more
It's gonna be
lumen.
butter, believe me.
And you can avoid the post dilation, because in my opinion, I never saw a supera deployment with a post dilation which actually increased
Increase the lumen.
increased
Yeah.
the lumen
Agreed.
significantly to a level where you
Agreed.
are procedurally
That's why I believe in
satisfied.
Yeah.
Totally agree.
So
PK, what do you think?
I think first and foremost, Supera, it doesn't have radial force. It's a non-compressibility.
Yes.
So it's a non-compressible stent. So if you have a non-compressible element that's deployed in a vessel that is or an lumen that is not an adequate site, is going to elongate. So that's why I was just telling Raman, whispering in his ear, sweet nothings, that what I was saying is that you have to prepare the vessel aggressively. So we prepared with a 7 millimeter balloon here, and Vishal, I think, can talk about the deployment and how it feels in your hands, Vishal.
Yeah, I mean, it's all about, like PK said, it's all about pre-drill, pre-drill, pre-drill. So if you prep the vessel well, the stent deploys very well. We usually start with doing half throws. I mean, unless you're expert like Karthik, you can just deploy it. But usually half throws gives it good control. Then you keep a little bit of forward tension if you have to stack it up versus just a little bit of tension to make sure
So remember,
it
around
opens up
15
well.
was where we had that recoil, Vishal. So Vishal's going to be a little careful around 15 because it might give him some resistance in his hands. It may not. I mean, it's really going to be where he does it. And for those at home, you see the two sides of the stent. It forms a line. That's kind of what you want to have. And if the lines are closer together, you're doing what Sardar said or Dr. Farhan said, which is stacking. And if the lines are well spaced, then
don't see the dots.
it's a little different. So right now he's deploying it, and we wanted to do it around 10 or 11, which is fine. I mean, right now I'm happy with this. So
It has
this
to open
is
up at 13.
yeah, it's fine. It's actually perfect. It's a demonstration of Vishal of a perfect deployment of a Supera, and more importantly, a demonstration by me and Raman of great vessel prep. That's the reason.
Perfect.
That's
Thank you.
definitely the reason. I think PK,
Okay.
I think that's actually true. Having a vessel prep is probably the reason for good superior deployment. If you don't prep the vessel very well, I think no matter how good of a I mean interventionist you are, it's going to be like it's going to be like going through hellfire. So
Well, so right now I pulled out the wire because I really feel we got a nice result. So I'm going to go ahead. I'm going to do my runoffs now. And Raman's going to give us a little dye. And that's, again, beautiful. There's a little bit of a collateralization dissection plane distally, which I'm not worried about. I think it's very short. You could argue, let's stent that, So that's done.
I think it's
I just
okay.
want to make sure that our distal vessel is okay. So again, I'm going to go to 48. And Bishal's going to just shut her in here for us a little bit. And what we're going to do is we're going to go ahead and do a nice prolonged DSA to make sure our distal runoff looks the same as it did before and after we started. So you can see you have wonderful flow in the PT, AT, and perineal. Good flow all the way down. And now, again, the reason we decided, you could say, why didn't we do atherectomy, which I think everybody in the audience has seen us do atherectomy over and over again. The reason is I felt the dissection plane was very large. And I think that in this case, we just go ahead and do a DCP Supera. I think we're going to be fine.
Beautiful.
So it's not that we're against doing atherectomy in these difficult dissection planes. I think that in this case, the dissection plane was too large.
yeah, I
So
think you're not going to achieve
very
anything by doing that.
I think it was a very nice demonstration of a short case. Let me come over here while Raman pulls the sheet out. And I have to tell you that the dissection this case really demonstrated how really there is no such thing as a simple SFA case. Anything can happen, and I'm glad that we struggled a bit. to show you the different mechanisms of opening up the SFA. I was glad that we struggled with the outback to show you some of the flaws of being in a large dissection plane and how you can modify that and respect the distal vasculature to be able to deploy the supera. I mean, Dr. Sharma went very nicely over the data. However, he forgot Imperial, but I think it's important to say that you have to apply the data to be able to be careful. As the wire comes out, you're going to feel resistance because of the tortuosity. Yep. So it's important to see that use that available data to formulate your algorithm. I don't think there's a right or a wrong in terms of treatment of this SFA. I just think that you have to get a good result and hopefully a durable result.
So, Dr. Krishnan.
And Karthik, thank you so much for making it on time.
No, thank you, PK. I think
and no, I'm all jokes aside. It was a fantastic case, and we'll see you next month. Thank you again.
Thank you.
Thank you very much. Thank you, Dr. Krishnan.
Thank you.
Thank you.
Wow, look at that.
I think it was a great demonstration. I think PK
Remember, I
had a
told you
very
to go
good
to
point to
Jinx
say that even the best of us have
Damien, can we have a
times when the
purpose?
simple case can be a very long
Thank you.
case. I think it's great to know when to stop and when to switch from access to another access point. You have to give yourself time, allot yourself time based on your skill level and your comfort level, and then change your access points and not keep doing the same thing as Dr. Krishnan was doing, like he was trying different things at the same time. So I think it's a fantastic demonstration, and thank you for joining us today. We will be very excited to have a lot of questions from you guys. Looking forward to it. And Sardar will definitely answer all your questions appropriately on time.
Hopefully. Yeah.
And then we would love to see you guys again next month on September 23rd for the live case webcast. Again, New York, Mount Sinai at 8 a.m. in the morning. Have a great day. Thank you.
Goodbye.